Good morning, everybody. Thank you for being here on time. Let's just start by really arriving here this morning. Uh, it's said that human beings are the only species that spends 80% of its time somewhere else other than where the body is, right? So you might be thinking about what you have to do next or what you forgot to do this morning or an upcoming exam or, how you're going to get through the weekend. Let's drop all of that if we can and just really come into this space and be here, body and mind connected, okay? And if it's comfortable for you, I'd just like to welcome us to just do a little bit of centering, right? I'm going to use this bell uh, just to bring us into the moment for a second, okay? So if it's comfortable for you, just put your feet flat on the floor, uncross your legs, sit in a noble, upright posture with your ears aligned with your shoulders, aligned with your hips. And if you like, gently close your eyes or soften your gaze and just listen for the sound of the bell. And bring your awareness to your breath for just a moment. Just breathing in and breathing out, not needing to change the breath, but just following the breath as an anchor for the attention. Follow the breath, and when you notice other thoughts arising, just let those thoughts go and come here back to the present moment, back to the present breath. And perhaps notice how quickly the mind wanders away from the breath and the present moment to plans, daydreams, fantasies, worries, whatever it is. When you notice it, come back to the breath. Super. Hopefully we're all here now. Take a deep cleansing breath, open your eyes, and we'll continue. It's so good to be here back in Dominica. Uh, this is the first time I flew in here. The last time I was here, I took my boat here and was anchored in Prince Rupert Bay, just up the other side of Portsmouth, and had a wonderful week. But I'm excited to be here. My name is Auguste Fortin. I'm an internist, recently retired from Yale School of Medicine, where I spent almost all my career in medical education. My interest is in the way doctors and patients interact with each other and how we can turn the doctor-patient relationship into a healing relationship. I went to medical school in an era where what we're going to be talking about today was not on the radar screen. I did not learn what we're going to talk about today. In fact, I was an attending physician for 8 years before I learned what we're going to talk about today. In large part because the research that informs the model we're going to talk about was not done when I was in my own training. But let me tell you something just at the outset. What I learned transformed my professional and honestly my personal life. What I learned allowed my patients to say some things to me that I had never heard, including, doc, I feel better already. Or, doc, I feel better just having come in today. And that was so exciting for me because I don't know about you, but I imagine this is so. That's sort of the sort of person I wanted to be all along, was the sort of person who could be a healing presence in another person's life. And this transformation happened before I wrote a prescription, certainly before the patient filled the prescription. It happened in that moment. So I'm excited to share this evidence-based model of communication that can allow you to be a healing presence in another person's life, as well as other benefits that we're going to talk about in a minute. Now, what we're talking about actually isn't all that new. It's just that we forgot about it. In fact, these words are chiseled into the marble of the Massachusetts General Hospital in Boston, in the US. Uh, the famous early internist at the turn of the 19th century, Francis Weld Peabody, One of the essential qualities of the clinician is interest in humanity, for the secret of the care of the patient is in caring for the patient. And the key here is that we need to let the patient know that we care for them. We're not just caring about them or for their problem. Um, so, a couple questions for reflection for those of you who are just starting out, and those of you who maybe learned the medical interview, but now we're going to expand the depth of that relationship that you might enter if you choose to. Uh, Lots of students are anxious about getting the interview right, and they're so anxious about it that they have trouble actually listening to the patient, right? You ask a question, the patient tells you, but you're already thinking about your next question, not what the patient is answering. And that can get you out of the moment, if you will. So, what skills and strategies are you going to use as a physician to listen attentively to your patients? How do you feel about asking your patients about their personal lives and their emotions? How do you feel about kind of deepening that relationship with your patients? How do you feel about becoming a therapeutic agent yourself by the way you interview patients? How personally involved with your patients do you want to be as a physician? These are questions I'm not asking you to answer right now, but think about them for yourself. Right? Being a physician is quite a bit different than most any other profession. We have a capacity to really be a healing force in people's lives uh, if we're willing. What will you do if a patient cries? I should probably word this slide, what will you do when a patient cries? Because in almost any specialty you choose to enter, this will happen. Well, what will your response be? What will your reaction be? What will it bring up in you? These are important questions to consider over the course of your training. So, the medical interview is a very special type of communication, very powerful type of communication. It's actually the most commonly performed procedure. Whatever specialty you end up in, you will do nothing more often than interviewing a patient. In fact, it's been estimated that the average physician does 200,000 medical interviews over the course of a career. If you're going to do something that much, doesn't it make sense to put some energy and effort into getting good at it, right? And getting expert at it and making it work for you and your patient, right? Another physician from the prior century, early in the prior centuries, Philip Tumulty, who was at Johns Hopkins University in Baltimore, Maryland, said, what the scalpel is to the surgeon, words are to the clinician. The conversation between doctor and patient is the heart of the practice of medicine. Notice he said conversation, not interrogation. Right? Many of us learn medical interviewing. What brings you in? What makes it better? What makes it worse? Does it travel anywhere? Have you had it before? What have you taken for it? That's not a conversation. That's an interrogation, right? Where were you on the night of August 24th? I mean, the patient gets nervous, they get shut down. So we want to change that model into a back and forth. And again, not new stuff. It's just that we forgot it with the ascendancy of science, right? So it's also the most powerful diagnostic tool. Now, that may sound like a bit of a crazy assertion when we've got PET MRIs and DNA sequencing and all the scans and tests that we can do. But it has been shown that if you're a good, successful, skillful medical interviewer, that is enough to get you the diagnosis most of the time. In fact, recent studies show that skillful interviewers can get the diagnosis that the patient is suffering from 76% of the time without anything else, without physical exam, without drawing blood work, whatever. Nothing else has that kind of power. So you want to be as good as you can at it. Skillful interviewers get more complete and more accurate diagnoses than interviewers who aren't as skillful. And for me, the word skillful means interviewers who are good at relationship centered communication, which includes patient centered interviewing, which is what really the focus, what we're going to talk about over the next few days. The medical interview isn't just a diagnostic tool, it's also a therapeutic tool, right? Patients feel better. There's evidence, research evidence, that shows that the patients of doctors who use patient-centered interviewing skills have lower hemoglobin A1C and lower LDL cholesterol than the patients of doctors who don't use these skills, who use the more early to mid 20th century interrogation skills rather than conversation skills. Pretty remarkable, right? That communication can result in better diabetes control. Wow. Better hypertension control. Hypertensives have been shown to have lower diastolic blood pressure if their clinician uses these skills. Shorter postoperative stays, shorter postnatal stays if the doctor uses these skills. Wow, how powerful, right? Less use of analgesics in chronic cancer patients, less use of opioid analgesics. Crazy, huh? It's also a risk management tool. One of the things we need to be aware of as physicians is avoiding mistakes and of avoiding getting sued for malpractice, right? It's important. And we know that these using these skills results in increased patient satisfaction. More and more, at least in the United States, patient satisfaction scores are being posted on the web for individual physicians. You don't want to be a two-star doctor. You want to be a five-star doctor, right? Because that's how you stay busy and active and have a successful practice. There's less doctor shopping, and anybody who knows that patients who hop from doctor to doctor get worse care, right? And there's less risk of malpractice suits, markedly less risk. What's interesting about medical malpractice suits is that they don't happen because of medical errors. Medical malpractice suits happen because of medical errors that happen in the context of a crappy doctor-patient relationship, right? The patient says, she didn't listen to me. She didn't understand where I'm coming from. She didn't seem to care. Notice that word seem, but now I want revenge, right? She didn't seem to care. I can promise you that almost every doctor on the planet cares deeply about their patient. But if the patient doesn't sense it, it's like a tree falling in the forest with no one there to hear it. Does it make a sound, right? If the patient doesn't sense you're caring, what good is it if it's just inside? So how do we help our patient know that we care? These skills will help with that. And it's actually an anti-burnout tool. You've entered this profession of medicine with open eyes, I hope. And you know it's a challenging profession. And you know that at least in the US, and I don't know about Canada, but I suspect it may be similar, there's a lot of physician burnout. People feel under the gun, feel under pressure, right? And we know that using these skills results in lower burnout, more job satisfaction, more professional satisfaction, more sense of work, meaning in the work, which is really, really important. So, if Pfizer made a pill that decreased A1C and LDL cholesterol, lowered diastolic blood pressure, and made you less likely to be sued, wouldn't you be prescribing a lot of that pill, right? But it's not a pill. It's simply a way of being, a way of showing up in the clinic room, in the hospital room, and working with this patient. It's very, very exciting stuff. So, I want to just back us up a little bit and start with some definitions and some history of the medical interview so that what's this guy talking about this stuff? My doctor never was like this with me. Where's this coming from? And I just want to sort of put some grounding on this so that we're all on the same page. So, the biomedical model happened at the very end of the 19th century into the 20th century. There was an explosion of science and technology. X-rays were developed around that time, early antibiotics early in the 20th century, insulin, things that allowed doctors to actually use science to impact patients' illness trajectory. But what happened with the biomedical model was the development of doctor-centered interviewing skills. Uh, the patients stopped trusting what the patient had to say and wanted to control the interview because they knew there was certain data they needed to get: onset, position, quality, quantity, radiation of the symptom. They needed that data, so they started interviewing in that way, firing off closed-ended questions. In the 70s, it began to be recognized, 1970s, it began to be recognized that patients were frustrated with this approach. They felt like they had to leave who they were at the door of the hospital or at the door of the office, because the doctor only seemed to care about their disease and didn't seem to care about them so much because of the line of questioning that the patients were exposed to. Right? And so researchers started looking at this and began to develop something called the biopsychosocial model, recognizing that it's not enough for a physician to be a good scientist and recognize the biological problem that this patient has. But in order to actually be the most effective doctor, you also need to understand the patient's psychological makeup and social situation. And any of us who've been a patient or who've shadowed in doctors' offices or have had family members who've been patients know that this is powerful stuff, right? That diseases don't exist in a vacuum. Diseases are very influenced by somebody's social situation, how much money they've got, whether they can afford their medicines, whether there's crowding in their home, right? And also somebody's psychological situation. Are they depressed? Are they defeatist? Are they going to fight this? Are they going to live with it? This all matters in a person's illness. So, in order to operationalize the biopsychosocial model, patient-centered interviewing skills were developed. And this required the use of open-ended questions. And let me just say a little bit about I've sort of talked about this, but there's a difference between a disease and illness. And this was not fully recognized through much of the 20th century until we got into about the 1970s. So the disease of type 2 diabetes may be virtually the same in patient after patient, but the way a given patient experiences type 2 diabetes is their illness, right? Illness, feeling ill or not with a given disease. So illness is very unique, whereas disease might be fairly standard across patients. There's also a difference between curing and healing. Most of us go into medicine because we want a cure. We want to stamp out disease, and it's a wonderful thing. But you'll find very quickly that you can't cure every disease that your patients come with. And some of the things that cause your patients suffering are really not, quote, medical at all. Poverty, abusive relationships, things like that are kind of uncurable, at least by us as doctors, but we can still be a healing presence. In fact, many people with curable disease have been traumatized by the medical system. And many people, if they had the right doctors with incurable disease, have been healed, even though that disease might be fatal. Right? So you notice the difference there. Yeah. So we've talked about doctor-centered interviewing skills being predominantly closed-ended questions and patient-centered interviewing skills using a lot of open-ended questions. And just to be sure that we're all frozen screen, eh, on the same, oh, yeah, before I go on. But we recognize that closed-ended questions have a value just as open-ended questions do. So what we want to do is integrate the use of open-ended and closed-ended questions in almost every encounter. I'll just do this. So let's be sure we're all on the same page with open and closed-ended questions, okay? So I'm going to show some questions and you tell me if it's open-ended or closed-ended. And just, does somebody want to give me a definition of a closed-ended question? Be brave. Exactly. Closed-ended questions are yes, no, or seven, a number or a word or something like that, right? And an open-ended question then is the opposite of that. That a question that can't be answered with yes or no, a question that draws out story or narrative. Excellent. All right. So open or closed? Closed. Good. Open or closed? Open, right? Notice you can't say yes or no to that. You have to tell a story. Good. Open or closed? Closed, right? In my knee or on this side. Yeah. And then open, right? Good. What more can you tell me? Open, right. How severe is it? Closed. Important question, but it's closed, and that's okay. It has a place, but we don't want to lead with that, is what I'm going to tell you. Is there anything you forgot to mention? Open. Now, grammatically, it's closed, right? Yes, there's something I forgot to mention, right? The answer could be yes or no, but patients interpret it, fortunately, as an open-ended question. Okay, good. Excellent, excellent. Now, what we're talking about, this evidence-based method of doctor-patient communication, has been published in a textbook. Now, I don't want you to think this is like an infomercial for August Fortin because I'm one of the authors of this textbook. 100% of the royalties of the sale of this book don't go to the authors. We're donating 100% of the royalties to the Academy of Communication in Healthcare, ACH. The Academy of Communication in Healthcare is a very cool organization that I would love for you to consider, and we'll talk about that at the end. But this book talks about, it's kind of small, but talks about everything you need to know in the medical interview. And if you have access to something like McGraw-Hill's MedAccess, this book is available there for hopefully for free for you. So how does this interview look compared to an interview that you might have experienced as a patient yourself, or you might have learned? What we're talking about in this model of integrated patient-centered interviewing is a model that front loads some of the patient-centered stuff in the beginning. So step one is greeting the patient, creating rapport. Step two is setting the agenda to be sure that you and the patient are in the room for the same reason. Okay. Steps three, four, and five are using specific patient-centered skills to bring out the patient's story, which has powerful diagnostic value, but also therapeutic value. It guarantees that each patient, each encounter feels heard, understood, and cared for. But then, of course, we transition. Oh, and here we're getting the beginning, the patient's version of the history of present illness. For you new students, HPI is how history of present illness is usually abbreviated. But even if your patient's a doctor, it's unlikely they'll tell you everything you need to know to be of service to them, right? So you do need to transition to the use of doctor-centered skills in the middle of the interview, where you will fill out or complete your HPI, history of present illness, and learn about other active problems, the past medical history, the family history, the social history, and the review of systems. For you new students, these are things that you'll learn in depth, and they require mostly the use of closed-ended questions. But we're front-loading these patient-centered skills and the use of open-ended questions for particular purposes. Now, imagine just because you're firing off a whole bunch of questions and you're maybe in the middle of taking the family history and you say, "How old's your mom?" And the patient goes, "My hope is your next question isn't how old's your dad?" Right? Right? You've got to recognize something just happened here. And you could say, "You seem sad." The patient says, "Oh, doctor, my mom just died last month." And that's an opportunity to return to a more patient-centered uh, stance, if you will, even though you're in the middle of asking those closed-ended questions. So it's not like there's a bright line and then we become, drill sergeants in the rest of the visit. No, we always remain aware and cognizant of the fact this is a human being, who's suffering perhaps on many levels in front of us. And then most encounters, after the history is taken, proceed with the physical exam and then ending the encounter with education, counseling, sharing a plan, further diagnostic workup, whatever is called for in that visit. So the entire model is outlined in the book is an 11-step model. What we're going to be talking about in the next couple of days is just the first 5 steps, because the remaining steps are pretty standard and haven't changed much since the 20th century. Okay, except for more awareness of people's social situations and the like. But I'm not going to be here talking to you about that stuff. So in the beginning of the interview, we're patient-centered, right? And in the middle of the interview, we're clinician-centered. And our job as sort of 21st century physicians is to synthesize these two narrative streams, these two stories, if you will, into a unified biopsychosocial story. And what has been shown is that you can do the bulk of the patient-centered part in about 10% of the total talk time. So this is not something that adds time to the encounter. In fact, and I'll show you this in a little bit, the research shows that this actually saves time. And not only does it save time, but it's been shown clearly that physicians who use these skills arrive at the correct and complete diagnosis more quickly than doctors who only use the blue part of the interview, the doctor-centered part of the interview. So there are tons of benefits to doing it this way. So in the beginning of the interview, I wish this worked. Yeah, we'll give it up. Uh, we want to create a therapeutic relationship. I talked a bit about that. We want to facilitate the patient telling his or her symptom story, right? Because narrative is important. If you've ever been to the doctor, you had a story that you were hoping to tell. And the way many doctors interview patients, you never got a chance to tell the story. You were just answering their closed-ended questions. Telling the story has relationship building value between you and the patient, provides you with diagnostically important information. The way a patient tells you their illness story is as important as the data that they provide in their illness story. And it's really, really powerful. And it also, for the patient, has cathartic value. The ability to share a story that the patient's been thinking about, even rehearsing with somebody who cares, is a powerful thing. Have any of you ever maybe had a breakup with a partner or something, or an argument, and like you call a friend or you call a family member, right? You don't call a friend or family member who says, well, you should have said this, or if I was there, I would have done that, right? You call a friend or family member who's a good listener, who says, wow, tell me more about that. Oh my goodness. Wow, right? You call a person who seems to care by the way they respond and doesn't try to solve your problem, at least in the middle, right? And then we want to listen to that patient's description of their symptom story, listen for personal context. We'll talk a lot more about that in tomorrow. And then we'll listen for and seek out emotional context. We'll talk more about that tomorrow. And we will respond to that emotion with empathic words. And that guarantees that the patient feels heard, feels understood, and feels cared for. Okay. So, and then lastly, oh, sorry, that we've broken up that beginning of the interview into 5 steps. Today, we're going to talk about the first 2 steps. Tomorrow, we'll talk about steps 3, 4, and 5. The steps are creating rapport, right? Sort of setting the stage for the encounter, developing that therapeutic relationship. The second step is eliciting the chief concern, the reason the patient's coming to the doctor, but also any other issues, and creating a shared agenda for the remainder of the visit. Then the third step is to begin the interview with non-focusing skills, open-ended skills that allow the patient to express him or herself. And then you'll use in step 4, focusing open-ended skills to learn more about 3 things: more about the symptom story, uncover its personal context, uncover the emotional context, and then respond with empathy. And then step 5 is simply a statement to transition to that blue part of the interview on the graphic, the middle of the interview, the doctor-centered part of the interview. So let's talk about step 1. And notice I've got some time marks here. This is efficient stuff. Everybody's busy. Nobody will do anything that ends up taking time, right? We need to do something that's either time neutral or saves time. This model actually saves time. And even if it doesn't save time in that visit, it will most certainly save time over time. But often it does save time in that visit. So, what does step 1 do? And again, this model is evidence based. Every sub step in the steps has some literature or at least expert opinion, but most of the time, actual research literature supporting doing it. Okay. So, the first is take a breath. Remember how we started this morning session with a mindful breath, right? Just kind of entering into the room. So mindful physicians have better patient outcomes and lower burnout than physicians who are just, running around like chickens with their heads cut off. And the environment is often conducive to running around like a chicken with your head cut off. But if you can take a breath, it matters, right? So some people will just put their hand on the doorknob and take a breath and just say, let me be whoever this next patient needs me to be, right? Other people will use the Purell, right, the hand sanitizer, and do an ablution, right, just to wash away the last patient and prepare yourself for the next patient. Whatever your practice is good. Some people will say a prayer. You enter the room and you welcome or greet the patient and whoever else is in the room, right? If you're running late, it's helpful to acknowledge the delay without groveling. I'm sorry I kept you waiting. Your time is valuable. Notice how you don't greet the patient by saying, "Hi, Mrs. Jones, how are you?" What's the risk of saying, "Hi, Mrs. Jones, how are you?" when you have your white coat on in a medical setting? Could you see a potential downside of starting off that way? What? Yeah, they tell you all the things you don't want to hear in that moment, right? Exactly. Exactly. Think about how many times you say, "How are you?" or "How you doing?" to your friends or colleagues, right? It's sort of a very typical way of greeting someone, but it's a big mistake in medicine to start there because the patient will either start with the reason they're, "Oh, my back's been killing me for 3 days," and you're just trying to create rapport. You don't want to hear the history of present illness yet, right? Or they'll say, "If I was well, I wouldn't be here," or, "I have cancer. How do you think I am?" Honestly, I've heard people say that when people start with "How are you?" So instead of starting with "How are you?" find another word, another phrase. I I I've been practicing this way for, I don't know, 25 years, and I still have to catch myself from not saying "How are you?" But I say, "It's nice to meet you," or "It's so good to see you again." Even though I want to say "How are you?" I don't say "How are you?" I say that. So really, really important point to get you off on the right foot. It's critical for relationship building to use the patient's name. All right. And generally, and this depends on the culture, the region that you're practicing, but many, many people prefer to be called by their surname rather than their first name. Right. Imagine being patient. It's very disempowering. You're frightened. Is this something serious? And you're ending up in an environment where people mistakenly might disrespect you by calling you by your first name. I had patients in New Haven, Connecticut, who for 20 years I called by their surname because I knew that in their church community, they were called by their surname, right? And who am I to think I'm flattening hierarchy by calling them by their first name? Nobody calls them by their first name. They're always Mrs. Washington, and that's how it is. And I want to be respectful of that. But other people would say, Mr. Smith's my dad, call me Jim. And I have permission to call that person Jim from now on. Right? But better to err on the more formal than the more informal. And of course, you want to introduce yourself by your name and your specific role. I recommend you introduce yourself by your first and last name, and it's helpful to hold up your ID card because some of us, if it's Bill Jones, most people will get that. But if you have a name, I mean, like my name is a French name, it doesn't, people kind of, what is that again? So holding up my card or giving them my business card allows visual learners to make sense of what my name is so that they know who I am. Okay. And remember, medicine is a team sport. So explaining who you are to that person and what value added you're going to bring by being there is important. Okay. If there are other people in the room, you want to introduce yourself to them and importantly, find out what their relationship is to the patient. I used to say, if my patient was Mrs. Jones and there was a guy sitting here, I'd turn to the guy and I'd say, "Oh, so tell me what your relationship is to Mrs. Jones." That's disempowering to Mrs. Jones, right? Right. So my practice now is, "Mrs. Jones, can you tell me who's in the room with us today?" So give Mrs. Jones the power to share that information, right? And then ask, and recognizing that this is a time where she may not feel comfortable saying, "No, I want him out of here," but say, is it okay if he stays here while we talk? We'll be talking about some personal stuff. But then, and I'm getting ahead of myself, but I'm sure some of you are thinking about it, make sure that you get to spend some time in the visit alone with that patient. Right? Even if as a male patient, with, for example, an observant Muslim female patient and a male family member accompanying them, I have to bring in a female medical assistant to get that time alone with the patient. It's important because the incidence of intimate partner violence in our current times is 20% in some situations, right? So you want to be sure that you can uncover that. Um, just because you walk in the room doesn't necessarily mean the patient is ready for you uh, to talk. I have, and some of my physician colleagues on the faculty may have had this experience of waltzing into a hospital room and starting to do your history and realize a few minutes into it that the patient's actually laying on a bedpan trying to go to the bathroom. Not very good for starting a therapeutic relationship, right? So, is this an okay time for us to talk, right? Or if you've got a teenage patient and you walk into the clinic and they're on their phone, maybe we can do something with that phone, right? So you can actually make some eye contact together, right? Removing barriers to communication is the next thing. There are lots of barriers to communication that you might be thinking about. One of the most important, and if you kind of get nothing else out of our time together this morning, one of the most important is to sit. Anybody aware of the data about what happens in a relationship and with communication when a doctor sits versus stands? Anybody ever happen to read that? Yeah. Yeah, when you stand, it makes the patient feel more intimidated. Yeah, definitely. And when you stand, the patient feels more disempowered, right? And if the patient's angry, it can raise the anger, right? So if I were to can I work with you for just a second? You just stay right there. If you were upset because you came to visit your mom in the hospital and she was covered with her feces and the nurses hadn't cleaned up, and you were understandably upset. And if I came and I said, so I understand that you've been kind of upset about the way your mom was treated. What would you be feeling right now? Probably even more upset and a little bit threatened, right? And you might be feeling a bit scared because this guy is standing over you, but who shows fear, right? Nobody shows fear. Anger is fear's bodyguard. So you're going to just show anger at me, right? But if instead I get at your level or even a little bit lower, which is what I do when patients are angry, I get a little bit lower. So now you can be alpha dog for a minute and I'll be beta dog. And it's fine with me. My ego can handle it. I say, boy, I understand that you've been pretty upset about the way your mom was treated. It helps, right? Even though it's a simulation, you can feel it, right? So these little things are so critically important. So sit down. Other data about sitting uh, is that even though the doctor thinks the visit will take longer, if you have a stopwatch, it's shorter, right? It's shorter. The data bits per second, if two people are at the same eye level, flows faster than if the doctor's above the patient. Really, really wild, huh? So, and lastly, sorry, I get so excited about this stuff. The patient's perception of the time you spent with them, if you sit, can be 2 to 3 times. And this has been repeated in several studies. You time it, and then when the doctor leaves, you say, Mrs. Jones, how long did the doctor spend with you? The patient will think you spent 3 times longer than in a same encounter where the doctor stood. So this is a win-win-win, right? So always sit, even if you have to sit on, a trash can or something like that. It's important to sit. Uh, oh, adapting your own language, pace, posture in relationship to the patient. So if you walk into a room and the patient's, like this, kind of involuted, it's helpful for you then to sit like this too. If on the other hand, you walk in and the patient's kind of gregarious and boisterous, well, you can be more open and that and match them, right? That's really, really helpful. Now, one thing I need to admonish you younger folks is that you talk a heck of a lot faster than older folks. Right? And I'm from New England, and we tend to talk a lot faster than folks in the South do. When I'm in my clinical role, I consciously slow my pace and rate of speech down and try to articulate clearly. English isn't the first language for many people. As people get older, it's well documented that processing speed, but also hearing decreases. So if you're there, so we got about 20 minutes together today. I want to, the patient's just not going to hear it, especially if they're older, right? Or if English isn't their first language. We won't even talk about using interpreters, but obviously, unless you are absolutely fluent in the patient's first language, use an interpreter. And even if the patient is bilingual, there's strong evidence to say it's worth asking, would you like us to use what language would you like us to use while talking about your health today? 50% of bilingual patients would prefer to use an interpreter when talking about their health. So that's important to know. Ensuring comfort and putting patient at ease. This is just a little bit of small talk, right? Maybe about the weather or sports. If somebody's wearing a team cap or a team jacket, it's safe to talk about sports, right? Something, or just, the flowers in the hospital, if there's any flowers or get well card or a book on the bedside table, you can use that to just comment, just to show you're a human being before you get down to business. So just a little bit of social connection or non-medical question. The next step, which flows directly from what we just talked about, and you'll notice it takes me a lot longer to talk about each step than it does to actually do each step, and we'll prove that to you in just a minute. Uh, it's important that you are not the only person in the room who knows how long you're going to be there. Okay? Right? So, one of the first things we recommend doing in most instances is letting the patient know how much time you've got together. Ah, it's kind of radical. Have you ever been in a doctor's office where they shared that? No. Yeah. When I first read this, again, I'd been an attending physician out of training for 8 years. I said, no way. Patients are going to go ballistic if they know my appointment's only 15 minutes or whatever. But why should I be the only one to know that I only have 15 minutes, right? So it all depends on how you language this. If you use the word only, you're putting a value, right? A negative value on that. Okay. And if you use the word you or me, you're creating some opposition. What we want to do is use words that that don't make it the time and me against the patient, but make it the patient and me against the time, right? So what I say is, so Mrs. Jones, we've got about 20 minutes together today, and so it's a matter of fact thing. I do it in a bit of a lilting style. It's very neutral or even a little bit upbeat, right? I have a friend who says, Mrs. Jones, we've been blessed with 20 minutes today, right? To really kind of lean into the fact that we're going to make the best use of this time. But if I said, Mrs. Jones, I only have 20 minutes today, ooh, puts a sour taste in the patient's mouth out of the blocks, right? Research evidence shows that when patients know the time of an appointment, the time length, it helps them organize their thinking, right? And if they have something important to get off their chest, they're more likely to get it off their chest at the beginning rather than at the end, okay? Once you've indicated the time, it's very useful to sort of forecast what you were hoping to do during this time, right? So, Ms. Jones, we've got about 20 minutes together today. I know I want to follow up on how your diabetes is doing, and I see that we need to talk about a couple of immunizations, something like that, right? But that's the first clause of a longer sentence, which is to prioritize getting a list of everything the patient was hoping to talk about. Um, has anybody ever shadowed in a doctor's office prior? Yeah. Have you ever heard a patient at the end of the visit say, "Oh, by the way, doctor?" Yeah. Happens all the time. It used to happen to me all the time. And the reason it happened is because I didn't do this. I thought my agenda was the only agenda. I walked in the room, whether it was an inpatient or an outpatient, and I thought the patient only had one agenda item. Yeah, I prayed they only had one agenda item. But the reality is that patients have multiple agenda items. Research shows that the average patient coming into a primary care office has between 3 to 5 issues that they're hoping to talk to their doctor about. In my patient population, which was underserved and really leading challenging lives, I'd say the number was 5 to 8. Now, it doesn't mean I'm going to deal with 5 to 8, but we need to get that on the table to figure out how we're going to manage this together in the time we've got. Okay. So you get a list, and using the word list is so helpful, because if you say, so Mrs. Jones, what brings you in today? That's not asking for a list, right? That's asking for the story of the first item on a list whose length you don't yet know, right? And you want to know what the list is, right? So what you're asking for is the title of things, whether it's a symptom a request or an expectation or an understanding or refills or forms, something. I used to get at the end of an encounter, the patient would pull out of their back pocket, "Oh, doc, can you fill out this disability form for me?" I just spent the whole appointment on a headache, and now this person just gave me 20 minutes more work to do now that I'm going to have to do in my own time, right? Instead, now you find out they have that disability form. You say, "Would you like to spend our time together filling this form out together?" And that's the visit, right? So time saving. And notice that what you do after each thing is you say, "Okay, blood pressure, what else? Or is there something else on your list?" Notice you don't say anything else. Why might we not say, "Is there anything else?" Huh? Yeah, you might receive anything, but it's also negating grammatically. Anything else? Patient's like, no. But if you say, is there something else? It's like you're presuming there might be more. So it gives the patient courage to share this thing. And what we know is the first item on the list often is not the one that you end up spending the rest of the visit on. It's the one that was safe for the patient to talk about first, right? And sometimes the very last item you get from the patient is the thing that drives the rest of the encounter. So this is time well spent. Yes, sir. Aha, very good. My next line on the slide. Thanks. So how do you figure out what's the chief complaint or chief concern? You find out, you summarize what you've heard, right? And then you say to the patient, so we've got this, and this. What's the most important thing to talk about first? You know? And you negotiate with the patient, knowing the time available. You've already told the patient the time, and you and the patient figure out how much of this list can we actually address today. So you create a partnership with the patient, you and the patient against the time, right, to maximize that. Right? And I'll demonstrate that in a second. So just because you hear it doesn't mean you have to deal with it. You negotiate the list down if it's too long to manage in the time. This is why you mentioned the time before you hear the list, because if you don't and the patient gives you a long list and you go, "Huh, we only have 15 minutes today," now it's you and the time against the patient. So mention the time up front. All right. So that's steps one and two. Only takes a couple of minutes, but it's money in the bank. Yes. So can you speak up just a little bit? I'm getting old and I have some hearing loss. With the 15-minute interview, I heard that. Does it take into account or an interpreter or something? Yeah. 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 So what do you do if the patient uses sign language or an interpreter or maybe has slower processing and you need to take more time? So you're getting to the crux of a huge problem, which is the medical system is fundamentally broken. And the idea of a 15-minute visit for patients who have increased complexity, for whom preventive care is much broader than it was back in the 60s when 15-minute visits were more the norm. Uh, and for whom we might need to use an interpreter, which means everything is said twice, which means the interview is twice as long by definition. These are all issues that I hope when the healthcare system gets exploded and rebuilt, we'll actually be able to account for in time. You know, it's a challenging time in medicine right now with the demands for throughput and the pressure of time. So right now, I don't have a brilliant answer. One way is to decrease the number of agenda items you deal with in a visit if it's going to take longer to talk about them because of an interpreter. Sign language is actually easy because it's simultaneous interpretation, whereas uh, language interpretation is asynchronous, so it literally takes twice as long. Right. So what I want to do now is just demonstrate how these the first couple of minutes of the encounter go. Um, Dr. Elena, do we have the pocket cards to hand out? Yeah. And Jordan, would you mind being my guinea pig? I mean, my patient? You can use that microphone. Have a seat. Mr. Mears. Yeah, great. Thanks, Jordan. Okay. So as Dr. Elena is handing out these pocket cards, I'm going to ask you to refer to them, just the first two steps. of the five-step encounter. These cards are for you to keep and hopefully stick in your white coat so that you can memorize this over time, and then you won't have to pull it out of your white coat afterward. But this was so transformational for me that is how I learned it. I made myself a little pocket card and I just pulled it out before I went to see a patient and kept adding steps to my method. So this is going to be an outpatient visit. All right. Mr. Mears comes in, and my medical assistant checked him in. And as I'm running around in the corridor between exam rooms, she says, "Oh, your next patient's here. He's got some ankle pain." So I come in knowing that. Okay. But I'm not going to assume that that's all that's going on, right? And let's say he's a new patient to me. He usually sees my colleague who's on vacation, so I'm pinch hitting, filling in, seeing some of my colleagues' patients. Okay. Uh, and I'm going to time this just for kicks. Not that I would normally do this in real life, but patient-centered interviewing looks like it takes a lot of time, but in reality, it doesn't take much time. And I think just having a stopwatch helps figure that out. And I'm just going to wait for a moment until we get the cards distributed so that you can follow the sub steps. And what we'll talk about is how did I do with individual sub steps. Some of them might not apply in an outpatient setting, right? But we'll see how that goes. So there'll be two cards. One is the five steps, and one is some empathic communication. So you'll get one of each card. But for today, for this morning, you'll just use the five-step card and focus on steps 1 and 2. And
Question.
yeah,
Is there anything that you do differently in an outpatient setting versus inpatient?
it's remarkably similar, outpatient versus inpatient, the patient-centered part. Yeah. The only time you wouldn't do this, if somebody's clutching their chest and turning blue, I mean, you're not going to set an agenda. You're going to take care of the problem. But 95 to 98% of them, if the person's unconscious, obviously, but you might do this with a family member, right? Because you've got to get the history somehow. Yeah. So it's very, very, very similar. Uh, Actually, on hospital day 1, when you're first meeting the patient, this applies, and it mostly applies on hospital day 2, 3, and 4 whenever you go in to see the patient in the morning. It's very, very important. Great. Everybody have a card? Okay. All right. Great. Okay. Knock, knock.
Come in.
Hi. Mr. Mears, is it? Did I get that right?
Yes, you did.
Hi,
Thank you.
hi, I'm Dr. Fortin. Here's my card. I'm a colleague of Dr. Jones, who I know is your usual doctor. Yeah, he's on a well-deserved vacation this week.
Okay,
It's
nice.
nice to meet you. Yeah, how was your trip into the clinic today?
It was okay. I'm in just a little bit of a pain right now.
Okay, yeah, I definitely want to talk about that. I just wanted you to know before we begin, I've been waiting all morning for a call from a consultant on my phone. If she calls, I'll just need to check my phone and make sure that it's her. It's a hospital phone, and if I have to step out, we'll make sure you get your full time for the rest of the visit. Okay,
Okay.
great. So they've given us about 15 minutes for today's appointment. My nurse told me that you came in with some ankle pain. I want to hear all about that in a minute. But before we talk about the ankle pain, was there something else on your list that you also wanted to talk about?
Yes, I would like to get a note for work.
Okay, well, that sounds important. So we've got the ankle pain and the note for work. What else is on your list?
Um, while we're talking, I think I need a refill on my asthma medication.
Well, that's important too. Okay, so ankle pain, note for work, asthma refill. What else?
I think that would be everything,
Okay.
actually.
So of those three things, which should we talk about first? What do you think is the most important thing here?
I would say my ankle.
Okay, I think we could probably cover all three of those items in the time we've got together. 1 minute and 34 seconds. Okay?
Damn.
Bam. All right. And I won't get so, whatever the patient's concern is, I'm going to spend all the visit time. And then if he says, oh, by the way, I need a note for work, now it's like, now I'm going to be late for the next patient. So now he and I know that we've got to tackle this in the time we've got. If the list was too long, I would have said something like, so, um, you know, of these 8 things you mentioned, which would be the most important 1 or 2 to to tackle. I don't think I'm going to be able to do a good job on all of those with you in 15 minutes, and then he'd tell me the one or two, and I'd say, well, let's see you back to tackle some of the rest. Okay. And you think maybe the patient would get mad, but if you share the time up front and you use this partnering, joining language, almost every patient is fine. And if they get mad and they stomp and now they have borderline personality disorder. You've made a diagnosis in the first minute and a half of the visit. It's remarkable. Patients are rational beings and they want to partner with you and they recognize the pressure that we're under in medicine. Great. Okay. Uh, Thank you so much. We will see more of this encounter tomorrow when we talk about steps 3 through 5. Before we break, we've got about 4 minutes. What questions or thoughts have come up for you in hearing this? What barriers do you foresee? What concerns? What excites you? Anything's anything's fair game. Yeah, yeah, for sure. Right. So preparing in advance. And my clinic in the last year I worked there allowed us additional time if there was an interpreter engaged in the visit. So that was hugely helpful. And they were really good about prepping it. Either the in-person interpreter would be there or we'd have the iPhone on a pole ready to, iPad on a pole ready to go. Already logged in. So my medical assistants were super helpful with that. Great. Any other comments, thoughts, questions? Yeah. Sorry, someone who is no, it's actually much, much, much slower for them to write it. And some deaf and hard of hearing people don't write all that well. It's not clear why, but that I've experienced that. So what you want to do is know that you've got a deaf and hard of hearing person coming in and arrange for a sign language interpreter to be there, either remotely or much better in person. And if it's an in-person interpreter, you don't look at the interpreter, you look at the patient. Okay. And what will happen is you'll be sitting here, the patient will be here, and the interpreter will be here. It's like a triangle, but your gaze should be on the patient at all times. And the interpreter will just talk what he or she is hearing the patient signing. Okay. And then when you ask a question, you still look at the patient. It's a big mistake and really insulting to deaf and hard of hearing patients if the doctor's focus is on the interpreter. The patient's the one coming in to get care. Yeah. So a good interpreter will set up the room and will coach you on that. That's important. Yes. Do I think 15 minutes for a patient is enough? I absolutely do not. Yeah. I would say that for some patients, a person who's socioeconomically stable, has stable housing, is in a stable relationship, has a good job, and comes in for a blood pressure check, 15 minutes is probably fine, right? But for my patients who were multi-morbid, right? Hypertension, obesity, obstructive sleep apnea, hyperlipidemia, type 2 diabetes, poorly controlled, food insecurity, housing insecurity, abusive relationship, uh, diabetic foot ulcer, and an hour wouldn't be enough for that, right? I think for complex patients, 30 minutes is probably good because there are so many psychosocial issues to be covered. But if all you have is 15 or 20, you partner with the patient in step 2 and figure out what can we do a good job on today, right? It's a fool's errand to try to deal with 8 things in 15 minutes. All right. And yet many of us, because of our nature, our curative need is what the psychiatrists call it, try, and it ends up nobody gets served well, and you end up cutting corners and causing harm. I honestly feel, as a primary care doctor, that the healthcare system needs to be exploded and rebuilt, honoring the complexity of patients and what we can do in modern medicine. Back in the 60s, I think there was just tetanus shot, right? But now there's tetanus shot, there's two or three different kinds of pneumococcal vaccine, there's H1 influenza vaccine, there's hepatitis B vaccine, there's hepatitis A vaccine, there's HIV testing. I mean, there's so that alone take 7 of the 15 minutes. So we haven't expanded the visit time to meet the increased complexity. And health maintenance back in the 60s probably maybe didn't even include smoking cessation because it wasn't quite clear that that was causing lung cancer. And now we've got all this, preventive healthcare, that the counseling that we're expected and should be doing to provide good healthcare. So there's a big mismatch between the system and what's really, the reality. I'm mindful of the time. It's 9:01. I want to, you know, I don't know what you all have next, but I'm sure it's important. I'll be back here tomorrow. We will talk about steps 3, 4, and 5, and then do a demo recapping steps 1 through 5. And then we'll have some time to practice on Wednesday, you guys practicing using this model so that you get the words past your lips. Okay? Great. Thanks for your attention.